We deal with the majority of ill health in this country, and we do it really, really, really well.
We provide 90% of patient care, and we only use up 9 or 10% of the NHS's budget.
We never discharge patients, we're never closed.
If we shut general practice overnight, the hospitals would fall over in 24 hours.
Someone coming in with depression, someone coming in with a possible heart attack.
Young refugee who has severe post-traumatic stress disorder.
Cancers, unfortunately, cardiovascular disease, respiratory disease, GI disease.
Could be anything from a 4-day-old baby to a 104-year-old and everything in between.
In my opinion, general practice is far less boring than most other hospital specialties.
Of all the words, it is totally wrong. Boring is the last thing general practice is.
Stupid. Oh, that's a bit unfair.
The word stupid does wind me up.
Well, I think that's quite offensive, really.
Part-timer.
I'm Deputy Course Director for Medicine at St George's, University of London.
I also work in the Paediatric Emergency Department.
Clinical lead for cancer in South East London.
I am chair of the Academy of all the Medical Royal Colleges.
You feel that you're doing something useful every part of every day.
There's probably not much that I haven't heard when it comes to derogatory comments or stereotypes.
Every day is full of challenges. It's an ever-changing job.
It's really easy to be a poor GP, and it's really hard to be a really good one. The most common response I would get from a consultant is, "Oh, Devon, you'll be wasted in general practice." My name is Dr. Devon Gray. I'm a salaried GP with additional roles in adult safeguarding, digital innovation and medical supervision. When I started medical school, I didn't have any idea what aspect of medicine I wanted to do, but I did know by the end of medical school I wanted to be a GP. I think that's partly because of the success of my GP placement. I found it a really exciting and inspiring part of the health service to work in. I didn't fall into general practice. It's something that I wanted to do after my experience at med school.
When you go to medical school and you kind of taste the different specialties, I definitely had a brief thought about going into surgery, but the kind of draw of family medicine, general practice just kind of, pulled me back again. I think that there is always a feeling that, it's a second-class decision, if you like. It's the easy road. People would think of it as a specialty where it might lack ambition. I've never ever thought of it like that. I've always thought of it as being a challenging thing to do. And I think it's probably the hardest type of medicine to practice.
I loved my F2 placement in GP. I loved my final year placement as well, and I think that's what kind of got that spark going. So my name's Elisa Jivraj, and I'm a GP ST1 trainee. So when I was a medical student, the idea of being a GP was, kind of not laughed at, but kind of looked down on us, I feel sometimes. I think that's why when we were told half of you would become GPs, that we were all sat there shaking our heads, that's not going to be me, because why would I ever want to become a GP? I think the perception was that people only went into GP because they wanted to have an easy life or an easy job. But then having experienced it, I don't think it is an easy life. So I think we need to get kind of past that misconception, really.
I think to some extent, in medicine as a whole, we have this slight factionalism, don't we, where each specialty and each group of professionals thinks that their specialty is the most difficult and the most challenging, and there can be a tendency in many quarters to look down on people outside that specialty, and I think that's certainly the case in some hospital specialties. One can argue that perhaps it's the case in non-hospital specialties as well, but I don't think I was really influenced by that very much at all, to be honest. I was always very clear in my mind that I wanted to be a generalist. I didn't want to limit my scope to one single specialty. I thought that I would potentially find myself lacking in stimulation if I did that. And those were the driving factors for me, if I'm to be honest.
There's a lot of derogatory remarks about you as a hospital trainee who people are knowing are heading for general practice as a career. So lots of snide remarks about you as you're practicing within the hospital. So I think that was the first encounter with it. When I was a more junior GP, and there were fewer investigations around for patients. There was that transitional kind of sigh in the medical registrar's voice as you tried to refer a patient in, that somehow you were being inadequate because you didn't know what the diagnosis was. I think some of that is that you were transferring medical uncertainty to them, and that was medical uncertainty they were going to have to take on, and they didn't really have the skills to be certain about it when the patient arrived. So there's a lot of kind of transactional denigration around referrals of acutely ill patients. So it's the kind of, why couldn't the GP have sorted this out? Why has the GP not done the right thing? Why is the GP's knowledge inadequate?
I heard comments about, why on earth would a GP want a PhD? What is research in general practice? That's a nonsense. I mean, some primary care research, the really applied end of research, so important, absolutely transformative when it's come to the management of so many diseases, be it atrial fibrillation, anticoagulation, respiratory disease. I mean, I just go on and on.
I think most of the misconceptions about general practice just come from a lack of understanding about the role. So if that's hospital colleagues who have only seen one aspect or had only think about those poor referral letters or referrals that come in. I think patients who've maybe only accessed the health service about relatively minor issues and therefore think that that's all that general practice does. And then I think you add on top of that the media, and that can really fuel quite a lot of misperceptions about what general practice involves.
It's probably a historical thing that, secondary care and primary care are different beasts really, and we don't have a lot of integration and connectivity, and I think there's a misunderstanding from secondary care about what we do in primary care and vice versa. So I don't necessarily think that they're looking down on us as such. I think it's just that they don't maybe understand what we do in general practice on a day-to-day basis. Yeah.
I think we've got to take a compassionate view of where it comes from. I think, medical registrars, gynae registrars or whatever are stressed often. Then it's a kind of easy hit as a vent for their stress when they're on calls. But I think we've got to look structurally at where it comes from, really. People who are being trained in specialties now are probably being trained by consultants who've had no experience of primary care. We've had F2s from, intensive care medicine who have come in completely confident about their acute medicine care, and they're completely thrown by the uncertainty of primary care presentations and have coped really purely. And I think it's been a really eye-opener for them to see what primary care is really like.
In terms of the public where it's come from, if you only have 10 minutes to spend with your patient, it's quite hard to get that connection in. So I feel that people just kind of get seen and, within 10 minutes and get told you can only talk about one problem, and they get frustrated about that.
Everybody has an experience of general practice from when they were a kid. So everybody has seen this tiny slice of what general practice is through the prism of their own life lens. And whether that is they had an ear infection and got dragged along by their mum, or whether they had acne and went along as a teenager or needed the pill to look after their periods. But that, of course, is the tiniest microcosm of what we actually do.
I mean, I think that the media, the print media, haven't necessarily been very supportive towards general practice in the past, and I don't think that that's particularly helpful. I think that we need to be, open and accept when we get things wrong, but I think media being critical without fully understanding what our job entails and the pressures that we're under, I think is unfair.
I think most GPs love their job, and I think it's really hard when you're then faced with quite negative media narratives about general practice, because patients read those narratives. One of my dearest patients, who's 86, I've known her for years, who I've been speaking to the whole way through the pandemic, said to me this week, "So when are you seeing face-to-face patients again?" And you just want to cry because she's obviously read that in the paper. And, you know, even people who you think that you know quite well, you know, think that we were closed even when we were seeing them or speaking to them regularly. So I think it would really help with morale if the media portrayed, and our colleagues, a more balanced view of general practice.
General practice is really a minefield of interesting pathology. We see patients of all specialties, of all age groups, in a variety of settings. We see acute problems, chronic problems, and so on.
I've worked in 3 practices really, in Hackney, Tooting and now in Brixton. You know, one of the best things about the job are the peers, because they're really good clinicians, really committed, enjoy the job in the same way. And that kind of fun of having undifferentiated symptoms presenting to you in patients that you may or may not have some knowledge of, and trying to understand whether or not there's something serious, significant going on or not, is a real joy. It's like detective work, really.
It's been a far more multifaceted job than I ever thought. I think I thought that I would be seeing, you know, just the kind of standard medical problems, finish my day, and I would have been fully comfortable with dealing with all the different problems that I would be encountered with. Whereas every day I go into work feeling challenged, and I equally get to the end of my surgeries thinking, you know, did I do that right? Have I missed anything? I'm not sure what's going on there. That's not something that that makes me anxious. It just makes me more excited that, you know, every day I don't know what I'm going to encounter.
I just laugh when people think that we deal with coughs and colds. GPs haven't dealt with coughs and colds for decades. We've got loads of other healthcare professionals who do that stuff. We do the difficult stuff, the complex stuff, the multi-morbid stuff, and the stuff that really involves understanding, yes, the medicine, the physical stuff, but the psychological, the mental health angle, but also the social and the side of people's lives too. You know, the quality of their housing, whether or not they're employed, what background they come from, what language they speak, the relationships that they live within are so important. And it's that interdigitation of all those things is just so rewarding and fascinating. You know, if you are interested in people, you can't fail to be interested in general practice.
Just recently, I picked up a very interesting, rare adrenal tumour in a patient who presented with back pain and who was being investigated and managed for his back pain for a while. Another really interesting patient that I saw was a number of years ago. It was a young gentleman who had been having abdominal pain, seemed very benign. He thought it might just be because of constipation, you know, really young guy in his 20s or 30s who had no other risk factors at all. And he had a really rare type of peritoneal tumour. And again, that was only picked up because of our diligence in primary care and our ability to carry out all of the necessary investigations that led to that diagnosis.
I'm just thinking about my New Year's Eve shift and the number of patients who were extremely unwell and refusing to go to hospital because of the fear of where we were at in the pandemic. And we had to keep patients comfortable at home who would have survived if they'd gone into hospital but were too scared to. And a very quick, oh, okay, I'll call the ambulance for you because your oxygen levels are 75% and you're hardly breathing. Normally a very easy clinical call is suddenly you're refusing to go in, you have the capacity to make that decision, and now I'm going to spend the next 3 hours of my on-call rushing everything in place to keep you comfortable at home because you are free to make that decision.
I've got a patient with bipolar disorder, and I've been working with him for probably the last 5 years, and there have been ups and downs in his health over that 5 years, which have been quite extreme, and that's been quite a kind of rocky journey that's involved supporting him, advocating with him at secondary care, and then having to section him because he'd become unwell, and then seeing him post-section to rather a good place where we are in terms of his treatment, where he's now very happy with the treatment he's getting and how he's feeling, and he's leading a kind of healthy, productive life.
I mean, I can think of a case not that long ago of going to see a lady on a home visit. She kind of answered the door and was kind of clutching her chest with her hand, and I said, "Oh, are you okay?" And she said, "Well, I've just finished lunch and I just can't get this," I think it was a sandwich, she couldn't quite swallow it, and she said, "Well, it's terrible pain in my chest." So I sat her down and she looked a bit grey and clammy. I said, "Are you sure it's just the sandwich that you've had difficulty swallowing?" And I have a single lead ECG on my phone, so I quickly stuck her fingers on there, and the tracing looked really abnormal. So I thought, this just doesn't sit right, is it something cardiac? And called the ambulance while I was with her. Luckily they came really quickly and put a 12 lead ECG on her chest, and she was having an acute myocardial infarction in front of me.
A chap was in the consulting room and he said, "You don't remember me, doctor, but he said 15 years ago you saved my wife from suicide." And it turned out that I had seen this woman, and I don't think I'd ever appreciated at the time just how emotionally vulnerable she was. And she hadn't revealed how bad she was, but she had told him then subsequently how bad it had got when she'd come into the consulting room that day to see me. Then, in a sense, what I didn't know was that I was the last stop before the bridge.
I mean, I think that the examination and history taking skills of experienced GPs are by far the best, of any specialty, because that's all we have, and we do it quickly. So, I think that OSCE type examinations are very rarely carried out in general practice because we don't have the time to do that. So that's a skill within itself, coming up with an abbreviated, if you like, examination and history. To come to a diagnosis.
I think that's something that I didn't really appreciate until I got into GP. Those resources are just not there, so you're having to really listen to chests and think, what can I hear here? Is this a pneumonia that I'm hearing? Or, you really do have to rely on your clinical skills, because yes, you might order a chest x-ray and some bloods, but those are not going to happen today, or you might not get those results back for over a week. But I've still got a patient in front of me who's a little bit unwell, and I need to do something right now for them.
When I made the switch to general practice, I think I was afraid I was going to feel lonely and isolated. It being part of a sort of basically a surgical speciality in sort of gynae oncology, you were always part of a team. There were always others around you, and so I think I very naively felt that. And I'd had good general practice placement experiences as an undergraduate, but I didn't know how typical they were. Of course, turns out they were very typical. And one of the best team sports in medicine is general practice, because you have got such a great team, and certainly the teams have just expanded over time.
The idea that you're working alone ever is just not true for any of the specialties, and certainly not true for general practice. So the people I work most directly with in the team are the clinicians. If we get stuck with a rash or a clinical sign, we'll go knock on each other's door and get somebody else to come and have a look. Again, if we're a bit unsure about what to do, we'll be knocking on someone's door to have a discussion in real time.
We work in a team where I work. We have an open door policy and have time every day to discuss and share complex cases. You never feel alone.
So people often ask me about whether there is an opportunity to progress in general practice, and I always find that question a bit odd. Perhaps it's to do with a misperception that once you become a GP, that is it, and you spend the rest of your life working as a GP in one role. But nothing could be further from the truth. From a basic lifestyle perspective, you can decide to work on weekends if you want, or you can not work on weekends if you want. You can work nights if you feel that works for you, or you can decide not to. And that level of autonomy and control that we have in primary care is really unique to medicine.
I've had this bonkers diverse career because of the flexibility that general practice has offered. I've been able to have this portfolio that's allowed me to be a GP partner, an academic, and work my way right up through the academic ranks, and have a medical political career, which has involved a media profile too. So it's pretty flexible.
You know, I've been a GP for 5 years now, and I know that there's just every year is going to present new challenges. And you know, the beauty of general practice is that you can adapt yourself, you can change roles, you can take on new responsibilities, and you can develop new interests. And you just can't do that in any other specialty. You know, I can't think of another specialty where you can keep diversifying your portfolio as you can in general practice.
You know, this career has got to last you a number of decades. I've got a good 35 years left. And the idea of being in a role that you can't evolve and develop and change as you change as a clinician is quite suffocating. And I love that with general practice, you can make it what you want.
How do you think we fix this?
I think that's really difficult, isn't it? I mean, I think that we just have to keep being, you know, positive about the job that we do. And I think that we have to we can't be inward looking, we have to be outward looking, and we have to go out and meet hospital doctors, junior doctors, medical students. We need to keep banging the drum for general practice.
I think one of the ways that we could do it is that, you know, you do have day swaps where you have people coming in. So maybe GPs can come into AMUs, acute medical units, and figure out what's going on there, because often their patients go there, and maybe those clinicians could come and sit with GPs for a day. I don't know if that would be a real kind of possibility, but it would be helpful, I think.
I think something that would really help towards addressing that is making sure that as many junior doctors as possible, as many foundation program doctors as possible, go through a stint in primary care, so they could be exposed to the huge diversity and the variety that general practice provides, so they don't end up with this incorrect perception that general practice is boring, because it's anything but boring.
In terms of the educator responsibility, I think what's really important is the students are not passive observers of episodes of care, and that educators engage even students who are determined to be bored as a participant in the care process. Because I think unless students experience the accountability of care, their responsibility for doing something for the patient, they're much more likely to be disengaged and find it boring than as an active participant.
At a micro level, actually on a one-to-one basis, we can call it out. So when those of us who are in positions to do so see it, you know, if we see medical students being disrespectful to one another or being unhelpful, call it out. If we see our colleagues being unhelpful in their attitudes, call it out.
I think that if all medical students had proper placements in general practice to see what the job was, then we wouldn't have these misconceptions. And also, you know, not hearing those narratives, which I heard not many years ago, even in those first lectures of probably most of you will end up in general practice, and said in a way that seemed very pejorative. But there's a responsibility, I think, for medical schools to put the record straight on general practice. From where I sit working in general practice, I don't really experience all of that negativity once you're in general practice, apart from the odd comment from a patient in the media. My experience of working with secondary care is extremely positive. My experience is of colleagues who are respectful and professional in how we work together. And I can't remember the last time I had an unpleasant interaction with a hospital colleague. So I don't know whether or not things are changing, or it's just that when you get into general practice, it's much better than you fear.
I think just stay positive, you know, and stick with it. And you know, I think it is an amazing job, and you will have so much job satisfaction and joy from being a GP.
I think if you know that's what you want to do, then just stick with your conviction and just carry on and do what you need to do to get there.
My advice would be to just stand up for yourself, give them a big smile and say, I think you'll really value having great GPs in the community, won't you? Because we're all working together to look after our patients. And demonstrate it, be a great GP, write fantastic referral letters, pick up the phone to discuss patients with secondary care colleagues, and just do your job as the best as you can. And I think that in and of itself will dispel misconceptions about general practice. My name is Dr. Devon Gray, and I am just a GP.
My name is Dr. George Pavey, and I'm just a GP.
My name's Dr. Elisa Jivraj, and I'm just a GP trainee.
My name is Dr. Judith Ibbison, and I'm just a GP.
My name is Dr. Hamid Khan, and I am just a GP.
My name's Professor Helen Stokes Lampard, and I'm just a GP.